We'll be talking about the interpretation and optimal use of inflammatory markers and hematologic parameters in COVID-19. So first of all, we'll be going over the various markers which can be elevated in this condition, and when ideally should one be testing for each of these, the clinical implications for the various biomarkers, special scenarios, and various diagnostic and predictive modules which have come in place. So as we all know, and Dr. Neeraj also talked about it, the severity of illness may range from mild, asymptomatic, and the disease, the natural history is such that it evolves into phase 2 and phase 3, but only in a subset. So the phase 1 is usually marked by fever and dry cough. Patient may experience myalgias, and sometimes if they worsen, they may have nausea or diarrhea, which is not persistent typically. They may have sore throat. But as the disease evolves in a subset of individuals, they may experience shortness of breath and hypoxia. And this is the phase where one needs to be careful and investigate these individuals. Phase 3 is seen in nearly 5% of individuals, wherein the disease progresses to ARDS, need for mechanical ventilation shock, or multiple organ dysfunction syndrome. So notably, some laboratory parameters may be deranged even in the early phase of illness, like lymphopenia is almost always present in individuals nearly in 80 to 90%, even early in the disease course. Occasionally, thrombocytopenia may be seen in this phase, and elevated D dimers may also be noted. But it is in phase 2, which is the pulmonary phase, wherein the patient develops shortness of breath with or without hypoxia, which are denoted as phase 2A and 2B, where we see all these ground glass opacities on CT scan. And this is the phase where patients may have more profound lymphopenia, progress onto even neutrophilia. The neutrophilia may be a result of or even resulting out of secondary.
Please mute yourself. Please mute yourself. Please mute yourself.
So in phase 3, we have a new set of biomarkers which comes in and plays an important role, wherein we need to look at cardiac derangement or AKI and other organ dysfunction, although the classic cytokines and marker panel which are used are also used for monitoring. So the importance of testing mainly lies in identifying the subset of individuals who are likely to worsen, or to confirm worsening in patients where clinical parameters are deteriorating. When we talk of worsening, it may include a cytokine release syndrome or macrophage activation syndrome, cardiac or renal complications, which are seen in a minority but may occur, particularly in those with comorbidities, or superadded infections. Thrombosis is another concerning complication, and D dimer is usually used to monitor for COVID-19 associated coagulopathy, and antiphospholipid antibodies have also been assessed at times, although these are not routinely recommended. And also testing is important for overall prognostication and follow-up. Now, there is a wide variety of parameters may be deranged in COVID-19, and this is a brief overview of all the parameters which may be deranged at some point. But the good news is most of the infections are asymptomatic. So 81% almost of cases are mild, no or mild pneumonia, and nearly 14%, 14 to 15%, up to 20% in some series may be severe and may experience shortness of breath and so-called pulmonary phase where they require monitoring. And it is only 5% who are critical, and by this time the patient is already in the hospital and may anyways be investigated. So these 80% individuals who have an uneventful illness would largely be comprised by fever, myalgia, sore throat, and uneventful recovery. And 15% have shortness of breath and hospitalization, and this is the time to test these individuals. So when do we test a person who is positive for COVID-19 is the golden question. So ideally it will be while entering the phase 2 of illness. Now the question is, how do we know they're entering the phase 2 of illness? Symptoms like persistent fever, diarrhea, persistent vomiting, a dropping SpO2. So as we all know, a PaO2 of 60 to 100 is reflected in a narrow range of 90 to 100 on SpO2. So even a drop from 98 to 94 to 95 may be a red flag if persistent and not accounted for by anything else. Also, a positive 6-minute walk test where the SpO2 drops to more than beyond 3% is a red flag. Apart from this, individuals who have comorbidities like the elderly, obese, diabetics, those with coronary artery disease or CVAs, any kind of chronic lung, liver, or kidney disease, hypertension, and those on immunosuppressants also need to be monitored closely. And the question is whether should we investigate at baseline? Definitely the subset with comorbidities, and we do not know who would be entering the phase 2 of illness. So if a person has persistent phase 1 symptoms, then they may consider testing. So we have various markers which are typically tested for in COVID. Procalcitonin has emerged as one of the popular markers, which we'll talk about in a bit, and CRP and ferritin are the most common markers tested. So in the early phase, the beginning of the pulmonary phase, they may be normal or elevated, and they are surrogate for host inflammatory response. So in the acute inflammatory state occurring due to COVID-19, the acute phase response, primarily driven by IL-6, induces the production of various acute phase reactants. So these are proteins whose serum concentrations either increase or decrease by 25% during inflammatory state, and these include CRP and ferritin, apart from various others. Now, C-reactive protein is a pentameric protein, which is an opsonin. So it basically helps in making the phosphocholine on the surface of these virions tasty for being taken up by the various host macrophages and other effector cells. So a C-reactive protein is usually less than 5 milligram per deciliter in a healthy individual, rises 4 to 8 hours after any kind of tissue injury or inflammation, and peaks at 24 to 72 hours. It may return to normal 2 to 3 days later, and the plasma half-life is about 19 hours. So since it is the sole determinant of circulating CRP concentration, it directly reflects the intensity of the pathologic process, which is stimulating its production. So this is a typical graph of CRP rise and fall with an inciting event, that is inflammation. And in COVID-19, when the inflammation is persistent, we expect it to continue being elevated. So some studies have shown that CRP has a very good accuracy in predicting severe COVID-19 at a cutoff of around 20 with an area under curve of 0.87 with a very good sensitivity and specificity. So the higher the CRP level, the more is the inflammation in a person's body, and CRP is not very specific. This is something you need to be mindful of if you think that the patient has two different conditions or CRP may be contributed for by something else, and it can help in monitoring disease progress and flares. So that was about CRP. Now the other marker which is frequently tested is ferritin. Ferritin is again an acute phase reactant which is induced, production is induced in the liver by rising IL-6 levels, and it not only promotes oxidative stress and also accentuates inflammation, a condition, a mechanism known as ferroptosis, which in turn contributes to inflammation and coagulopathy. So so ferritin is also a surrogate for macrophage activation, and beyond a certain point, once ferritin has risen, there may be a late hepcidin mimic effect. So the ferritin may continue to increase independent of the inflammatory response. So even though the CRP may begin settling, ferritin sometimes may continue to be high for a bit. And it may also be an important predictor of death at very high values like above 1,000, and different studies have shown different cutoffs ranging from 700 to 1,500. Where it may at times have a better area under curve for prediction of death in COVID than even procalcitonin on CRP. The other marker which is frequently used in our setting and elsewhere as well is lactate dehydrogenase, which is an enzyme found in nearly all living cells. and this signifies tissue necrosis and may be surrogate for severe COVID-19. In fact, it is suggested that a value more than 273 in this small series, it was very well predictive of the risk of death. But it is important to be mindful that false positives are very common with LDH, particularly because it is present in nearly all cells. And something as simple as a hemolyzed sample or a sample which was just pushed rapidly into the tube, again contributing to hemolysis, may lead to falsely elevated LDH. So if you have only rising LDH and nothing else, then you maybe need to think of local factors and not really with that prompt with action. The other marker which is being widely used in our ICUs is serum procalcitonin. So this is a short peptide which is also shown to have a significant association with COVID-19 severity. Typically, it is a biomarker of bacterial infections, but it is shown that overall rise in procalcitonin correlates with severe COVID-19. The cutoffs may be debatable, with some studies suggesting a cutoff of 0.05 and others suggesting 0.5. So procalcitonin testing on admission, patients particularly going to the ICU, may be a valuable additional piece of information for early risk assessment and to rule out bacterial co-infection. But monitoring of PCT, it is useful mainly for detection of secondary infections or progression to a more severe disease state. So indications for testing procalcitonin may be a worsened clinical status, critically ill patients for follow-up monitoring, and established infection to supplant assessment of the response to therapy. So once the patient moves on to stage 3, which will be only 5% of our patients, the same markers will continue to be useful, and almost all of them will be highly elevated, except procalcitonin, which may even be normal because it is not typically high in viral illnesses. But new markers may assume importance, particularly cardiac biomarkers, because they have a very good predictive value in assessing organ dysfunction and death. This is also the phase where cytokine release syndrome and macrophage activation may be seen, and cytopenias may be observed. So talking in brief about the various hematologic manifestations of COVID, lymphopenia is the earliest. And
Latika, do you think
yes,
you could finish in the next couple of minutes?
yeah.
3 minutes? Okay, thank you.
Yeah. So lymphopenia is the earliest and most common marker, which is present around 83%. And with regard to neutrophilia, this also may be a marker of severity. And typically there's a shift to left when it comes to granulopoiesis, mainly because of the disordered granulopoiesis and hyperinflammation. So important to be mindful that neutrophilia may be triggered by severe disease, by steroid intake, or by bacterial co-infection. The other markers which have been suggested for use are NLR ratios and lymphocyte to CRP ratio. These are simple and cost-effective techniques for assessment of severe COVID. And then thrombocytopenia, which may be due to decreased production or increased destruction and occurs in nearly 50% of individuals. For severe COVID, so maybe we can skip the prediction modules, and notably AKI may be seen in 20 to 30% of COVID, and it has been associated with an increased mortality risk. Cardiac biomarkers are a severe red flag when present because they directly correlate with mortality. So any elevation of cardiac markers below the upper limit of normal is very dangerous and mandates careful reassessment of the patient. COVID-19 coagulopathy, mainly marked by elevated fibrinogen and D-dimer, may be associated with increased risk for thrombosis and mandates careful monitoring with a D-dimer elevation of more than 1 microgram per liter is a strong independent predictor of mortality. It is important to be mindful that of the fact that patients with liver failure or immunocompromised state or other inflammatory disorders, these acute phase reactants may not mirror true states. And various centers, this center has come up with a machine learning based prediction module for assessment of severe COVID and suggests the use of these 3 simple markers LDH more than 365, hsCRP more than 41, and lymphocyte count of less than 14% for predicting death in severe COVID. And when the daily tally is so high, sometimes you can't even get to book a COVID-19 RT-PCR. So the authors of this group came up with this online calculator to predict the risk of a positive COVID, and something which may be used in our setting when we can't get a COVID-19 RT-PCR. So take-home message is that judicious but diligent investigation is advised, and one should consider baseline tests when necessary, but follow-up is largely based on clinical assessment. And watch out for poor prognostic markers, especially in patients with comorbidities.